So we're good to go now, sir. We're on live.
Yeah, thank you. Good afternoon, doctors. Welcome to this webinar on the role of Oseltamivir in flu management. This webinar is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare's journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities. With 300 plus production portfolio and presence in 126 plus countries, Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Heathrow Healthcare is amongst the largest manufacturers of ARV, APIs, and FDFs in the world, and as Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Heathrow Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. Heathrow Health during COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patients, because of which in August 2020, Heathrow Healthcare received an award for COVID drugs, Award of Pharma Excellence. Today's webinar role of Oseltamivir in flu management, we have Dr. Pramod sir as our moderator, and Dr. Sanjay Nathu and Dr. Anil as speaker. Dr. Pramod is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI CSO 2016 to 19, Chairman Minir SP Module IIP, author of book Cophology. Once again, welcome Dr. Zog. Dr. Sanjay Nathu is MD DNB Pediatrics, MN AMS FACEE, currently Professor and Head of the Department Pediatrics from March 22 till date at Srimati Kashibai Navali Medical College and Chandra Hospital, Pune. Sir is consultant pediatrician, Shashwat Hospital, Kothur, Pune. Areas of interest include pediatric pulmonology, pediatric infectious disease, pediatric emergency medicine. Sir has been President IIP Pune branch 2021 and member of Pediatric COVID Task Force, Pune Division. Welcome, Dr. Sanjay Nathu. Dr. Anil MU is MBBS MD Pediatrics, Fellowship in Pediatric Critical Care, DAA, Diploma in Allergy and Asthma. Sir is Lead Consultant Pediatrics and Pediatric Critical Care at Sparsh Hospital, Bengaluru. Welcome, Dr. Anil. And with this brief introduction, I hand over the session to Dr. Pramod Sukh, sir. Sir, over to you. I'll stop sharing.
Yeah. I'll just share my screen.
Yes.
Yeah. Okay. Is my screen visible?
Yes, sir.
Okay, thank you. So, good afternoon, friends. We will be discussing an important topic related to influenza management, and that is the use of Oseltamivir in flu management. And influenza is an important respiratory infection in the pediatric population. And we are all aware that in 2009, we had the pandemic, which was famously known as swine flu pandemic. And people still have that particular name in their mind. And this particular disease has taken toll over last century in different countries. I will be telling you a bit more about the pandemics of influenza, but it is very important that we are aware of different details related to this illness and the management and the prevention part. As you can see, I have put my name in the fashion of the nomenclature of the influenza virus, which usually includes the place of origin and also the year of origin. This is to bring uniformity in identification of the virus all over the world, because influenza virus keeps changing its structure every year, and we will be discussing even this aspect of influenza virus. So influenza is very common during monsoon, but it does not mean that it only occurs in monsoon. It occurs all around the year in parts of India like Maharashtra and Karnataka and Goa and the western side. It's usually more seen during the monsoon and in the period just after monsoon. However, in areas like Kashmir and Kanyakumari, it is seen towards the end of the year, like in November and December. And there are many experts who recommend the vaccination depending on the prevalence of monsoon in those areas. And as all of us are aware that during COVID, most of us were indoor, children were indoor, and that's why the immunity against certain viruses did not develop to a great extent. And that was one reason as to why, some of these viral infections, they started showing themselves as the COVID pandemic started declining. For example, we came across hand, foot, mouth disease, respiratory syncytial virus, the adenovirus, then measles in some areas where measles immunization was on the lower side. So all these viral infections, they started showing up after the COVID pandemic started declining. And it is very well known in the virology that when one of the viruses is predominant in the atmosphere, other viruses usually do not show up. But as COVID pandemic started declining, viruses like influenza also started showing up. And that was all because of what is called as immune debt, which was there during the pandemic of COVID. And in the post-COVID period, we are witnessing that even older children are getting affected. There was a 3-year-old boy who came for fever, cough, cold, and progressive breathlessness over 3 days with tachypnea and hypoxia. This particular child was admitted. An X-ray of the chest was taken, which showed a picture like ARDS. And this child was ventilated, received oseltamivir and supportive treatment, and the nasopharyngeal swab was positive for H3N2. He was ventilated for 3 days, and then he was all right. Everyone started discussing about the fact that in a previously healthy child who presents with cough, cold, fever, progresses over 3 days, and worsens during this particular course, whether we can prevent this particular progression by early use of oseltamivir, particularly in the flu season. And that's why there are many points which produce confusion, that is, confusion in the relation of this influenza virus, whether it is bacterial or viral. If it's viral, which is the type of virus, whether a rhinovirus, adenovirus, influenza, parainfluenza, RSV. If it is influenza, what is the type, whether it is H1N1 or H3N2, and whether one should start oseltamivir upfront. We are going to discuss most of these points during the discussion today. And one should be aware that in monsoon, there are many healthcare related challenges, and most of these are under the group of what is called as influenza like illnesses, which commonly come with cold, cough, and fever. However, influenza is the one which I call as the father of all influenza like illnesses, because it has all systemic manifestations like severe headache, high fever to begin with, along with muscle pain, weakness. And we have seen parents lifting up older children and bringing to the clinic. So that much is the weakness and prostration. In general, over last few years, the mortality and the morbidity related to influenza is on rise. We should all be aware of the KYC of this naughty influenza virus. These are the details. Just as we submit our know your customer details in the bank, we should be aware of this naughty virus. I call it naughty because it's an RNA virus, and almost all the RNA viruses, they are known to change their structure. For example, COVID, dengue, RSV, influenza, all these are RNA viruses. And influenza virus is commonly divided into three types: influenza A, B, and C. And influenza A is the one which is responsible for frequent epidemics. Every year, the strain changes. That is because of the changes in the antigens on the outer side of the virus. It also is responsible for periodic pandemics, and that is due to major antigenic variation. The minor variations are called as drift, the major variations are called as shift. Influenza B viruses, they infect only human beings, but influenza A will affect the human beings, the birds, animals. And when different viruses from these three different creatures, they come together in some third party, for example, a virus from the bird and a virus from the human beings mixes up in the pig, then a novel influenza virus comes up, and that is exactly what happened in 2009 when the pandemic came up, because the novel influenza virus comes in circulation in the atmosphere and people don't have immunity against that particular virus, and that is the cause of rapid spread of these viruses in the atmosphere. This virus has hemagglutinin and neuraminidase on the outer side, and both these glycoproteins have their own function. For example, hemagglutinin helps this influenza virus to get itself attached to the respiratory epithelial cell, and the RNA of this virus enters into the host cell, that is the respiratory epithelial cell. There, the RNA multiplies because it dictates the DNA of the host cell to produce its own copies, like RNAs. And so many virions, RNA molecules are produced, and they are ready to get out of the respiratory epithelial cell. And there is another enzyme of the virus, and that is neuraminidase, which acts as a molecular scissors, and it literally cuts the different virions into different RNAs, and these RNA molecules, they are about to get out of the respiratory epithelial cell, and the molecule oseltamivir, if given on time, usually stops this particular release of the virions and infection of the other respiratory epithelial cells. So these two are very important proteins, and there are some 16 hemagglutinin glycoproteins and 11 neuraminidase glycoproteins, and a combination of these in different forms like H1N1, H2N2, H3N2, all this produces different types of viruses. And they are the ones which many times are responsible for either epidemics or pandemics. And there have been four major global pandemics till now. So the first one was in 1918, 1919, and that was known as Spanish flu pandemic. And that was related to H1N1. At that time, obviously, vaccine was not available, even the antivirals were not available. But at that time, there was unusual high mortality of young adults between 20 and 40. Children were not involved at that time. And the main management at that time was non-pharmacologic. People simply received bed rest and they improved on their own. However, this pandemic came in three waves. That was, in the spring of 1918, then in the fall of 1918, and then early 1919. And the origin of this pandemic is still not very much clear even to the virologists. However, there was a lot of mortality, and almost 50 to 100 million deaths were reported worldwide, and one third of the global population was involved in this. Then there was another pandemic which was in 1957, which was commonly known as Asian flu, and it was related to H2N2. And then there was 1968 pandemic, which was Hong Kong flu pandemic, which was H3N2. And in 2009, all those who had suffered during this 57 or 68 pandemics, they had a bit of immunity, and that's why those who were above 65 years, they were not affected to a great extent in 2009 pandemic. And that was the pandemic where again the children and the young adults were the ones who were involved to a great extent. So influenza has always created a major problem all over the world, and in US, influenza vaccine is one of the important factors connected with the elections, as to who would win. The one who would assure that influenza vaccine would be available, usually he gets the upper hand. Anyway, so with that, Dr. Anil, what is your opinion about the current epidemiology of influenza in the pediatric population?
Yes, sir. Good evening. Yeah, this season, I think all of us experienced this wave. Quite a bit of wave was there starting from the monsoon season, from probably end of June onwards, even till now, we have been getting lots of flu cases. And since the PCR technology has evolved and we are getting these swab reports now, we're able to identify the subtypes of these viruses as well. Like Sir has already told us about the types, that is type A, B, and C. And what we have been getting this season has been largely influenza A. Particularly in that influenza A, we have been getting the H3N2 subtype quite a bit. H1N1 also it is there, but lesser in number. And yes, sporadically we have been getting some cases of influenza B, and influenza B probably the seriousness is much little lesser. Fortunately, that's what we have seen so far. And in that also, we are seeing only the Victoria lineage of late. And even the WHO and the CDC, who have been tracking these viruses and the subtypes of this, they've seen that less and less of B type is being seen, and especially the Yamagata lineage is no more found in circulation. That's why probably in the coming days, the recommendations have been to scale down the immunization from the quadrivalent to probably a trivalent. That's what we are going to use in the next season. So this season, majorly H3N2 and sporadically H1N1 is what we have been seeing, sir.
Thank you. Nantu, do you have any additional observation about the epidemiology?
No, good evening, everyone. So, no, I agree with what Dr. Anil has said. We had quite a substantial number of patients coming up with influenza, and we were also having a similar finding like H3N2 was the most predominant strain which was isolated from these patients of influenza. And we did get occasional H1N1, the pandemic strain, occasionally, and just maybe a couple of them were influenza B. So no, you are absolutely right. H3N2 is the same strain which we also isolated here in Pune.
Right. So this flu virus basically spreads to others up to about 6 feet, and these viruses they spread mainly by the droplets when people with flu cough or sneeze or talk, and these droplets land in the mouth or the nose of the people who are nearby, or possibly they are to be inhaled into the lungs. And Dr. Adil, what are the different clinical scenarios with which influenza virus can present in the pediatric population?
Yes, sir. This has been a common scenario of late, and as and when we are seeing more number of immunization take up in the community, we are left with to deal with the flu and flu-like illnesses. And typically, they are coming to us with a acute febrile respiratory illness. They may have acute onset of fever, which is sometimes very high grade to start with. Even on day one, they start with a high grade fever, severe myalgia, malaise, cough, which is non-productive. And also, what typically we have seen is little older children can complain of a very severe sore throat on day 2, day 3. They complain of a severe sore throat. They'll have other mucosal involvement like lot of rhinitis, conjunctivitis, and these kind of symptoms. And the body pain is very intense. They come to us with intense headache, body pain. All these things are there, and we have seen these are the respiratory presentations of it. At the same time, because of the high fever, we have seen increased incidence of febrile seizures, encephalopathy, and rarer presentations of myocarditis, all that. And this being a viral illness, we are seeing the gastrointestinal involvement also in some children. They may present with vomiting and diarrhea. But generally, it's been the self-limiting viral kind of illness is what we have been seeing. Like the children, what we see in the OPD present to us with fever, cold, and cough, which is self-limiting with supportive care and symptomatic care. Things are subsiding on its own.
Dr. Sanjay, do you have any additional observations about the clinical presentations?
So I agree with Dr. Anil. The majority of our patients have been the typical fever, cough, cold, coryza, body ache, headache type of patients. We do get occasional patients. In fact, the number of patients presenting with gastritis or gastrointestinal symptoms is also quite substantial. And occasional patients with neurological symptoms or neurological presentations are also quite commonly seen.
So it is important that we should understand that behind all this symptomatology, there are two things. One is that the direct damage to the respiratory epithelium, which is responsible for this cough and sore throat and other features, that is a direct viral invasion. While there are symptoms related to the cytokines, which affect the different systems, and the severity of these symptoms is many times related to even the cytokines, and many times these cytokines come into the picture after 4 or 5 days. And that's why it is essential that these children are rather monitored over next few days, so that the cytokine related symptoms or so-called cytokine storm can be detected little early. And there are quite a few different illnesses which present in more or less similar fashion, and they are all grouped as either influenza like illnesses or H1N1 or the severe acute respiratory infections, or COVID-19, all there are so many others, and it's very difficult to differentiate one from other, though there are minor symptoms which would probably help us in differentiating. For example, during COVID, we had loss of smell and loss of the taste. And there are symptoms related to influenza, which we discussed in the earlier part. Dr. Anil, would you just like to tell us about the emergency warning signs of flu sickness so that the pediatricians are aware of these and then they can, inform the parents accordingly?
Yes, sir. The emergency warning signs or the so-called red flag signs is what we would call. And like I told you, majority of the viral illnesses are self-limiting that we would see, which will settle on day 4, day 5. But at the same time, we should be very careful and probably we should educate the parents also about these emergency warning signs as to when to seek care, when to get the children back for a review or to seek further medical attention. So these are the general warning signs which I think all pediatricians we keep telling our patients about. Specifically in cases of flu, we should look out for the respiratory signs and the general wellness signs. The general wellness signs being how active the child is doing in between the fever spikes, how good is the oral intake, how good is the urine output, and how consolable or how active the child is in between the fever spikes. When we look at the other danger signs, if we come system wise, we look at the respiratory system. They may develop signs and symptoms of low respiratory tract infections, and the general pneumonia warning signs that we tell about. That is, any respiratory rate which is increasing more than 40, retractions the child is developing, or a very severe cough bouts which inhibits the child from eating or drinking. These are the things that we look out for in respiratory. Neurologically, we look at the activity of the child. If the child is becoming drowsy, if the child is becoming very lethargic, inability to feed or drink, or any kind of seizures, these are the things which we look neurologically. And the general well-being, or if they have any other concerns, we ask them to report back to the hospital immediately.
This is very important so that the parents can keep a watch on some of these symptoms. And in case if the parents are working, they can even inform the grandparents or the caretakers in the house so that they would be vigilant. And remember that these various points are, rapidly progressing. And that's why a child who is, appearing well in the morning may not be that well in the evening. And that's why it's necessary that one knows about all these. And there are some complications of flu, which, for the sake of convenience, I have enlisted beginning with alphabet A, like acute respiratory infection, which could be either pneumonia or ARDS. This could be related to the direct viral invasion, or it could be related to the cytokines. And then acute otitis media, absenteeism from the school because of the sickness, and the impact on the income because of the parents, those who had to stay at home for children, and also antibiotic abuse, because sometimes it's difficult for our colleagues to differentiate, and that's why they end up prescribing some antibiotics because of uncertainty about the diagnosis. Whatever it is important to know that flu is not a simple illness, and the treatment of influenza is based on certain categories. Dr. Sanjay, I would like you to tell our listeners about categorization of influenza into different categories, and also the management, which is based on categorization.
Yes, sir. So basically, the influenza or influenza-like illness has been categorized into three types: category A, category B, and category C. Category A is the typical patients which we see in our OPDs. These are the uncomplicated or mild type of influenza or influenza-like illnesses. So these patients present commonly with fever, cough, throat, body ache, headache, etc. And the features are fairly mild. And these children have a self-limiting course, and they usually start recovering by about day 3, day 4, and so on. The category B is the next category, which is a little severe symptoms. These are other severe symptoms, or the symptoms may be mild, but the patients belong to a high risk category. So they may have some predisposing factors or comorbid conditions going around. When we talk about severe symptoms, that means a very high fever or a very bad painful throat would categorize the child into category B. And when we talk about the predisposing factors or the comorbid conditions, the most important being age. So, a child who is less than 5 years and more so who is less than 2 years would be categorized in category B, even though the signs and symptoms may be mild. Similarly, elder age group more than 65 years or children or adults having chronic health issues or chronic comorbid conditions like say lung problems or a heart failure or a heart related issues or maybe diabetes or children who are on some immunosuppression due to some other reason or an asthmatic, all these children would come into category B. The last category is the most severe, that is category C, and this includes all the patients which are present in the severe presentation. With they have all the red flags or some of the red flags which Dr. Anil was talking about. So they may have breathlessness, chest pain, severe drowsiness. They may present with shock, maybe hemoptysis, or they may have CNS manifestations in the form of altered sensorium, occasional seizure maybe, or a somnolence and so on. So these patients belong to category C. When we look at the management of these patients, so category A is usually the mildest version which we see in our OPDs. They do not require any IPD management. They can be managed at home with just home isolation, adequate rest, plenty of fluid so that they are well hydrated, and only paracetamol as an antipyretic. So that is a very simple management for category E. There is no question of testing, no specific management required. For category B, so these are those with severe symptoms or those with some predisposing or comorbid conditions. Now, these patients definitely should be put on antivirals as soon as possible, preferably within 48 hours of onset of symptoms. In this category of patients, you may think of testing, but though you have to remember that it is not mandatory that you have to test. You can directly start the patients on antivirals even without getting the test result or even without sending the sample. Category C obviously are severe symptomatic patients, and they usually are always are admitted mostly in the PICU or the high dependency units, and they require aggressive supportive management along with obviously a very early starting of the antiviral, that is oseltamivir. So the oseltamivir needs to be started as early, maybe within 48 hours or even sooner, and of course aggressive management is required in these patients.
So, knowing that the categories are there, it will always help our colleagues to manage accordingly. And before proceeding to the further discussion on some cases, it is necessary that we know a bit about this molecule called oseltamivir, which, as I told you earlier, blocks the viral neuraminidase enzyme, which is critical in releasing virions from the infected host cells. And basically, oseltamivir is a prodrug which is converted into active form oseltamivir carboxylate in the liver. And this was the first oral neuraminidase inhibitor, and it is approved in more than 100 countries. And CDC and American Academy of Pediatrics have approved this particular molecule. And the dosages are important because in adults we give it as 75 milligram capsule twice daily for treatment and 75 milligram capsule once daily for chemoprophylaxis. And in children, the dose depends on the weight bands, right from infancy up to beyond 40 kg. And the medication is also available as oral suspension, which contains 12 milligrams per ml for each dose. Remember that the chemoprophylaxis is to be given for 10 days and the dosage is in the single daily dose form. Dr. Anil, I would like you to tell us as to how does early initiation of oseltamivir influence the clinical outcome in a given patient?
Yes, sir. Thank you. So, as you rightly explained, sir, oseltamivir is the neuraminidase inhibitor. The function of neuraminidase is to help release of these virions. The RNA virus enters the host cell, multiplies in huge numbers. So it's an exponential multiplication, and more number of virions are released into the environment to infect the other host cells. And this kind of cycle goes on. So by using oseltamivir early, when I say early, I mean to say one between the before the first 48 hours of symptom onset, if that is done. So the neuraminidase inhibitor, what it will do is it will prevent the release of these virions from the infected host cell, thereby spread limiting the spread of these virions to other secondary cells and thereby the secondary organs which will be involved. So the multiple studies, what it has been shown is initiating this treatment early will lessen the duration of illness by good 24 to 48 hours. So considering how serious this infection can be at some times, so that reduction of 1 to 2 days will be quite beneficial for anybody who has gone through this severe illness. Coming to the second set of patients that we get in a referral places where we do more of inpatient work, we do see kids being referred to us on day 4, day 5, or even later for the complications also. So whenever, especially with the backdrop of this monsoon and an epidemic of flu going on, whenever we suspect, even that thought comes that this disease could be secondary to a flu, I think empirically we go ahead and start them, whether it is day 4 or day 5, really doesn't matter. Empirically, we do start them on the drug, and if it is indicated, we get it tested also. So even on day 4, day 5, it is found to be beneficial as it stops the spread of these virions to the secondary organs and thereby shortening the entire course of the illness. It's quite beneficial to start it as early as possible.
It is very important. And just as we saw in the initial case which I presented, this child was put on oseltamivir on admission in a serious state. Even then, this molecule helped, in the faster recovery. And all these facts have been substantiated by different clinical trials, and all of them have shown that oseltamivir use in influenza illness reduces lower respiratory tract complications, antibiotic use, and hospitalization, which is true even for adults. And WHO has recommended empiric treatment to be started as soon as possible. And even in absence of positive laboratory confirmation, this oseltamivir can be administered whenever you clinically suspect influenza. We will be discussing a few cases so that some of these concepts are clearer. And Dr. Sanjay, this is a child coming to us with fever for 3 days, cold, cough, and the child has been on metered dose inhalers since 4 months. The child is overall well controlled, but after giving this symptomatic treatment, he returns back after about 3 days with similar complaints, just remaining febrile for a day and developing fever, cough, cold again. And in between, of course, he has been quite active. The parents are worried. And as we discussed earlier, these viral infections, have rather become quite common. Even the recurrence of viral infections has also become common. And, these are occurring at even shorter intervals. So parents many times, are under the impression that use of antibiotics will help my child, and doctor, please give antibiotics. And many of them, they go even up to the extent of pressurizing us to give antibiotics. So in general, looking at this particular case and what we observe in our practice, how would you counsel the parents about such situation?
Absolutely right, sir. So, in the last 2, 3 months, we have seen several of such type of patients who had these episodes of viral illnesses lasting 3 to 4 days, getting better for 2 to 3 days, and coming back to us again with similar episodes. Naturally, the parents being very concerned why the child is getting these infections. So when speaking with these parents, we need to take a look at certain things. For example, why is the child getting such infections? Is he going to a creche or a play group where he's getting exposed to multiple viruses? That is something we need to discuss with the parents. Also, we need to tell or highlight if the child is doing well in between the infections. How is he? Is he active? Is he eating? Is he growing well? And that is something which we need to point out to the patients, parents, that the child is growing well, his weight is being increasing, his height is increasing, and this is best illustrated if we plot it on a growth chart. So maintaining a growth chart for the child and showing that the child is growing well in spite of these minor infections would go a long way in convincing the patients, parents, that these are just a part of the growing up process. In addition, we can also tell them the common fact which we know, that in the preschool age group, children tend to get 6 to 8 or even up to 10 infections in 1 year, and that is just a norm for most of the children, and we need not be worried about those. So we need to take time out for the patients, understand their concerns, why the parents are concerned, and try to address their concerns, and that would help us to convince them that there is no need for any antibiotic, and the child is otherwise normal and growing well. So we just need to take these infections with symptomatic management, and that is it.
Yeah. Dr. Anil, do you have any additional inputs on what Dr. Sanjay told us?
No, sir. Sanjay sir has beautifully summed it up. Spending those 2 extra minutes with the patient, reassuring them, understanding their anxiety points, and addressing them. Many a times, reassurance is the only thing that they will need. I think over the last few days, I've been trying this. So I'll tell them at the end of my thing that I really don't have more medicines to give your child. Only I can give my reassurances to you, telling that your child is perfectly fine. This is a normal part of growing up. So we just tell them reassurance is all I can give and not to worry. I think that kind of helps.
Right. And coming from the mouth of a senior pediatrician or a qualified pediatrician does make a difference. So if we tell them authentically, usually they listen. I many times feel that we call ourselves as consultant pediatricians, but many times our role is for counseling. So one should start calling ourselves as consultant pediatricians, counseling plus consultation together. And that's very important. And that is true for quite a few illnesses. And Dr. Anil, I remember you telling us once that you should tell the parents that cough and cold are to be considered as another member of your family growing with your children. So that's the best way to tell them, so that they take it as a part of normal growing of a child. And it's also important that our colleagues are aware of some organisms which could be clinically thought of by what is called as educated guess. For example, a child coming for cold, sneezing, and simple upper airway involvement in the form of mild or no fever without any exhaustion, and simply a runny nose could very well have rhinovirus. Adenovirus, of course, presents a bit differently with pharyngoconjunctival fever, sometimes diarrhea, sometimes mesenteric lymphadenitis, and sometimes hemorrhagic cystitis. Children who are under the age of 2 years, particularly under the age of one, they come with bronchiolitis because of respiratory syncytial virus. And some bacteria like strep pneumoniae, they will produce pneumonia with fever, grunting, tachypnea. Some others like group A beta hemolytic streptococcus, they will produce involvement of tonsils producing follicular tonsillitis and tender cervical nodes. And staphylococci will produce a rapidly progressive picture where the child will appear more toxic. And organisms like mycoplasma usually affect older children, and children come predominantly with cough. So the knowledge of the clinical presentation will also give us a bit of a reassurance about what we are dealing with till some laboratory reports are available. So, Dr. Anil, this was a child, 4-year-old with cough and fever of high grade since 5 days, not settling with oral medicines. He was admitted, and on admission, he had tachypnea and needed oxygen support. The counts were 1620 with platelet count of 132,000. The liver functions were mildly deranged, and the nasopharyngeal swab showed positivity for H3 and 2. He was detected to be a case of influenza with low WBC count and low platelet count. Now, with this particular scenario, I will just like you to analyze this case for the benefit of our listeners so that they would know as to how to approach when such a child comes to our OPD or in the
Yes, sir.
hospital.
So this child, 4-year-old, we are seeing on day 5 of illness, and this straight away comes into category B or even C because the child is already tachypneic, requiring oxygen support, and already being treated and with symptomatic medicines and not getting better. So straight away, we would end up admitting this patient who's requiring oxygen, may end up in the ICU or HDU depending on the unit policy. So at admission, we see that the child has low respiratory signs, tachypnea, retractions, and probably crepitation. So we would treat it like any other child with pneumonia. So this child, if they're coming in the monsoon season with the backdrop of this epidemic of flu that is going on, flu should be our first diagnosis. So even before we get all our bloods and the other nasopharyngeal swab reports, empirically we go ahead and start this child on oseltamivir in such a situation. And of course, antibiotic also is, it's again a $1 million question, when to start antibiotic, when not to. But if child who's coming as sick on day 5, we would take appropriate cultures and probably worthwhile to start antibiotic. We can always de-escalate later on. So usually we get our reports in the next few hours. So the reports will be reassuring that it's more like a viral kind of a scenario of 1600 total counts and the platelets being on the lower side. So our choice of empiric choice of oseltamivir we can substantiate over here, and the transaminases also are slightly on the higher, little raised. So this is one situation I think we should be little careful, especially in the monsoons. We have high endemicity for dengue fever also. So we have seen and even burnt our fingers sometimes when the dengue uh, is coexistent, or sometimes the rapid test may falsely flag dengue being positive. So both situations we should be comfortable to evaluate further to rule in or rule out the dengue fever. And of course, nasopharyngeal swabs, if you are able to get a diagnosis, which is very much possible nowadays in tier 1 and sometimes even in the tier 2 cities, it is very much possible. Only in the remote taluka level, probably it is little difficult to get these swabs. So even in the absence of this, if the child is in category B and C, like this child is, I think it's worthwhile to start both on IV antibiotic and oseltamivir with or without the swab testing.
Thank you. The cause for the low WBC count and the low platelet count usually is because of the suppression of the bone marrow. And one should remember that whenever you get such a picture, it is better that you put this child on oseltamivir empirically. And of course, we came across some other children who were H3N2 positive. In some of them, the CRP was on higher side. Of course, in one of these children who had high WBC count and high CRP and continuous high fever, we got adenovirus positive, and that's how this throat swab helped us in finalizing our treatment. Dr. Sanjay, this was a 5-year-old girl who came for high fever for 5 days, cough, cold for 5 days. The child was sick with mild wheeze, but there were no crepitations, and that's why the parents were interested to know whether one should rather put the child on antibiotic therapy. So looking at this clinical scenario, what would be your thought process?
So this is a 5-year-old girl who has had a high fever for 5 days, which is usually a little longer than a typical viral type of illness. Cough and cold is also there. So whenever there is a cold or a runny nose, that again points towards a viral illness. However, this child looks a little sick and has also developed lower respiratory signs in the form of wheeze, though there are no creps right now. So if you look at the description, this looks like either a prolonged viral infection or a severe viral infection, but you cannot rule out a bacterial infection in such a situation. So you have to be cautious and you may think of starting an antibiotic in this child, along with, of course, an antiviral. So an antiviral would be my first choice in this child, but then I would also think and err more on the side of caution and start an antibiotic as well.
Okay. So this particular child was put on amoxiclav. The WBC count was 2800. The differential count was neutrophils were 10 and lymphocytes 70. CRP was 34.7. And this child was put on oseltamivir. And when the nasopharyngeal swab report was expected, it was reported as rhinovirus positive. So with this, in addition to the therapeutic decisions, I would like you to, tell our listeners a bit about the tests which are used for the diagnosis of the viruses in the upper respiratory tract, which can probably rather spread down to the lower respiratory tract, and whether you can base the treatment decisions on those reports.
Yes, sir. So there have been a lot of tests now which are being done for these viral infections of the upper respiratory tract as well as the lower respiratory tract. And the most important of these are the PCR-based tests. So these are either single-plex PCR tests or multiplex PCR panels wherein a lot of viruses are checked for or looked for in a single sample. So we have to remember that we have to use the test in accordance with the clinical picture. So no point doing tests in each and every patient. At the same time, another important point is that these tests are quite sensitive. So if you do the test properly, for example, in the upper respiratory panel, you need to take a nasopharyngeal swab. So if a deep nasopharyngeal swab is taken properly with the oropharyngeal swab as well, then the results which you get from these tests are quite good, quite reliable, and you can base your treatment decisions based on these results. At the same time, one has to keep in mind that if the clinical picture is not matching with your what you are getting in the lab, then you have to evaluate whether the test has been done properly and whether you need to base your management on these tests. For example, in the case which you have showed, the child looks to have a typical influenza-like illness, while as the report has shown rhinovirus, which is a very mild sort of illness lasting 2 3 days with just fever, if at all, and more of runny nose and all. So this is not matching with the clinical picture of which we have been presented with. So in this situation, I would not decide my treatment solely based on these tests. I would probably continue oseltamivir, but with the other lab investigations which can be seen to be more of a indicating a viral infection, I would probably stop the antibiotic in this situation. So good tests, but they have to be evaluated along with the clinical picture. And remember, if you are seeing a typical influenza-like illness, especially category B or category C, then you do not do or wait for these tests. You start the antiviral as soon as possible, preferably within the first 48 hours.
Thank you. Dr. Anil, this was a 7-year-old daughter of IT sector parents, came for high fever for 3 days. There was throat irritation. The child had her examination in the school 2 days later. The throat on examination showed mild congestion. The child was prescribed paracetamol, and in view of the flu and the adenoviral cases going on, the parents wanted to know whether it is necessary to do the investigations, the throat swab, and whether it is necessary to put on empiric oseltamivir. So, in such a situation, how would you approach this case?
Yes, sir. Many a times we do come across this situation where clinically also we are pressurized, and because of social situations like this exam or the parents being highly educated and they want more details, we come under a lot of pressure in such situation. This is where the utility of this categorization of A, B, and C, severity of illness, will come into play. I think we should always fall back upon that, and we can always educate the parent. Probably, in fact, open it in front of the patient about these categories, category A, B, and C, and tell them, see, your child is fitting into only category A, which is a usually just self-limiting kind of illness, just fever, sore throat, and all this will settle down in the next couple of days. So we will keep this child under follow-up. We will give a full supportive care like good hydration, paracetamol, and close observation after explaining them all these red flag signs. And I think this much of counseling should do, sir. If at all pressurized to the extent, and then probably we can ask for a throat swab if at all the father or the parent insists on it. But again, really not required in this situation.
Of course, Dr. Sanjay, in this particular child, where, a 3-year-old boy who came for cough for a week, high fever for 3 days with crepitations, and who was put on coamoxiclav and admitted for persistent fever and put on IV amoxiclav, where the WBC count, the CRP were almost normal, and the throat swab showed influenza A, for which oseltamivir was added. What will you do to the antibiotics which have already been started? And this is a very common dilemma in the practice, where already the child is put on some antibiotic, then there is either report positive influenza or no response to antibiotics. Someone adds oseltamivir, and then there is always a question whether we should stop antibiotics or continue. So how would you look at this?
So if you look at this particular case, this patient seems to have cough for 1 week and fever for 3 days, and already lower respiratory involvement is there, and he has got persistent fever. So I would probably definitely think of starting antibiotics upfront along with oseltamivir, especially in the given situation when we had this epidemic-like situation. So coamoxiclav plus oseltamivir would be justified. But once you look at the lab reports after initial stabilization, they would point towards a viral picture as far as the labs are concerned, and the presence of a nasopharyngeal swab PCR, which has shown influenza A, would definitely justify continuing obviously oseltamivir, but I would be comfortable stopping the intravenous antibiotic in such a patient.
So this is a part of what we call as antibiotic stewardship, where if it is PCR positive, then one can always decide about stopping the antibiotics and at least not escalating them in a given situation. There have been quite a few other cases of influenza this particular season. And Dr. Anil, there was a child, 1 year old, with fever, cold, cough, and came with status epilepticus. The nasopharyngeal swab showed H3N2 positivity. The counts were normal, and the MRI showed non-specific encephalitis changes. The CSF was normal, and this was diagnosed as a case of influenza encephalitis. So I will just like you to tell our listeners about some neurologic complications related to influenza.
Yes, sir. This season we did see few neurological complications of influenza, much more than the previous years, probably. So what we saw is, I would like to say it in different age groups. Probably the smaller children came to us with increased high-grade fever that has led to increased incidence of these febrile seizures. So they were mainly admitted for management of febrile seizures, and because of this high spiking fevers, and later on were found to have influenza positive. And also, we had other children who came to us with very high grade fever and delirious towards the high grade fever. They also improved with symptomatic supportive care of fever management. And then we had one patient who came to us with multiple episodes of seizures and not child not regaining consciousness in between. So this child was pretty sick, had to be intubated, ventilated, and the MRI done also had shown deep nuclear involvement, like bilateral thalamus had these lesions with a central necrosis also, what we would usually see in a JE kind of a situation earlier. And this child, lucky for us, improved, but we had to do some immune modulation in this child because the CSF did not show us any cells, and we had to get this, and it doesn't show come positive for the multiplex PCR studies in the CSF. Here in such situation, because there was a background of febrile respiratory illness, we had to do a respiratory panel for which was positive for flu, and the CNS manifestations were explained because of the cytokine storm, because of increased interleukin 1 and 6 mediation. The CNS had taken a hit, but lucky for us, this child improved. But generally the prognosis is quite poor if the child presents to us with a what we call as a ANEC, acute necrotizing encephalitis kind of a picture. And we had few cases who presented to us like with GBS, and also there are few cases described in the literature with aseptic meningitis, though we didn't see any aseptic meningitis this time.
Great. Thank you very much. Actually, these neurological complications like encephalopathy and encephalitis are a rising concern. And I was just going through a CDC report where influenza-associated encephalopathy, that IAE that we discussed, about 9% of the pediatric flu deaths had this IAE, influenza-associated encephalopathy. And according to this report, which I just read 2, 3 days back, many children with this IAE or this acute necrotizing encephalopathy who died were previously healthy, and the vaccination rates in this group were very low. So this underlines the importance of immunizing children against influenza. There have been quite a few other complications which our colleagues have seen in different parts of the country. And some of our colleagues have reported lot many cases related to influenza plus respiratory syncytial virus infection. Even in our institutes, we came across quite a few cases of co-infection. And there have been some reports about some other respiratory complications related to influenza also. We have discussed otitis media and pneumonia to some extent. Dr. Sanjay, will you like to add anything related to the respiratory complications which we have discussed till now?
Yes, sir. So rightly you have pointed out otitis media is quite common. Pneumonia, almost 15% of these influenza patients may get secondary infections. But the other complications are also not to be forgotten. So the dreaded one is the ARDS, that is acute respiratory distress syndrome. And children, that it's quite a severe situation which requires very intensive management to get the patient out of the situation. Of course, children who are having asthma, we have seen several of them coming to us with this viral influenza and exacerbation of their symptoms, which required additional management as well. So that was quite common. Occasional patients landed up with respiratory failure, and a couple of them also presented with cru-like symptoms. So the acute laryngotracheobronchitis with a hoarse voice and a brassy cough and all that stuff. Though commonly seen in para-influenza, even influenza virus can cause this type of situation occasionally.
Okay. Of course, we also have seen children coming with influenza and toxic shock syndrome, occasionally myocarditis and pericarditis, and myositis, which is more with influenza B in boys who are 6 to 9 year old with bilateral gastrocnemius and soleus involvement, coming with severe bilateral calf muscle pain and inability to walk. And during our residency days, we commonly used to see this Rye syndrome, which was associated with influenza B children receiving salicylates. Fortunately, this complication has come down over years. There are some quick questions for both of you. So, Dr. Anil, there is an elder sibling of an 8-month-old child who is admitted with influenza A for LRTI, and the younger one, the 8-month-old, develops fever, and now the pediatrician has a question whether he should put this younger one on oseltamivir.
Yes, sir. Right away, yes, I would say, because this 8-month-old child comes under high risk group. So anybody who is less than 2-year old is considered as a high risk group for developing influenza and its complication. We have an index case who is already tested positive for influenza A. So this child very well deserves to be started on oseltamivir, not just the chemoprophylaxis. This case, because child is becoming symptomatic, we should go ahead and start the child on full treatment. That is a twice a day dose, 3 mg per kg of Oseltamivir for 5 days.
Okay. Dr. Sanjay, if a child doesn't accept the oral medicine, what is the strategy to be followed?
So unfortunately for the influenza right now, only oral oseltamivir is the drug which is available. No other medicines which can be given by other routes are available. Fortunately, oseltamivir is quite well accepted orally, and it has very good acceptance even for from small kids who take the syrups as well as the capsules in the older children or adults. So that is the only way which we can give the drug.
Okay. Dr. Anil, what is your opinion about chemoprophylaxis to the household contacts where a child in the family has been detected to have influenza?
Yes, sir. The household contacts who are at high risk, for example, who are aged 65 and above, they have other comorbidities such as a diabetes, they have a chronic lung conditions like a COPD, asthma, or they're immunosuppressed, maybe because of chemotherapy or a long-standing connective tissue disorder, steroids being taken. So all these category of patients who are at high risk, like even pregnant mothers who are at home, should be started on chemoprophylaxis. But whereas a young, robust, healthy adult can be excused from the chemoprophylaxis, explaining them all the danger signs.
Dr. Sanjay, does oseltamivir work in patients who are diagnosed as para-influenza cases?
So the straightforward answer is no. Oseltamivir is only for influenza. It does not help in the para-influenza infections.
Right. So these points were only to clarify what we have discussed till now. What we have learned is that influenza is a fast and a furious virus. The onset is abrupt, the transmission is high, the progression is rapid, and some children may develop complications like ARDS very fast. And that's why we also should act very fast and use antivirals like oseltamivir quickly. In addition, it is important to prevent influenza. So when you come across any child or an adult who has influenza, it is better to educate them about prevention. And we all of us are aware about SMS, that is sanitization, mask, and social distancing, following cough etiquettes like coughing in the elbow, and following certain rules related to the hand, which I would put as Hasta Pancha Sutri, 5 rules, 5 sutras related to Hasta, that is hand, like frequent hand washing, avoiding hand shaking, use of handkerchief, and keeping other people at a hand's distance, and also avoiding hand touching. These things are important because the virus, if it sits on the palms or some body surfaces and then gets transmitted to the fomites like the tabletops or the laptop tops or hands or handkerchiefs, then the spread is faster, and that's why we have to be very, very careful. Particularly, we should also remember about flu vaccine, because as healthcare workers we are susceptible to get flu very, very commonly, because children many times directly cough on our faces. Our staff members, the receptionists, ayas, and the ward boys, they are also in contact with people, children with respiratory infections, and it is prudent and wise to get ourselves and our staff immunized by a flu vaccine, which is effective to an extent of 60 to 70%. The effectivity depends on the match of the strains in the vaccine with the atmospheric viruses. That means if the match of the viruses in the vaccine is equal to the match with the atmospheric virus, then the efficacy is always better. And that's why it is important that every year one shot of flu vaccine is taken. And I always like to tell our parents, in addition to saying happy birthday to you, one should say happy birthday to flu also, because there are parents in the house, children in the house, and so many others. And that's why, along with celebrations for the birthday, one should also take a shot of flu and protect from this preventable disease. In fact, it is important to immunize everyone against even pneumococci, because pneumococcus and flu both are important causes of pneumonia in children, and they are eminently preventable. Even children with flu, as we saw, get complicated by a secondary infection with streptococcus pneumoniae, and that's why it is said that 25% cases of flu get secondarily infected with streptococcus pneumoniae. So combination of both these vaccines will go a long way in prevention of problems like pneumonia. So with that, we come to the end of this discussion, and from all of us, myself, Dr. Anil, and Dr. Sanjay, we say namaste, because we have already said that now shake hand. In future we are going to restrict ourselves, so that we do not spread these viruses from at least our end to the society. Thank you very much. It's over to you, Dr. Prashant. Yeah.
Thank you, sir. Consulting is a new word I learned today.
Yes.
As usual, lovely. It is always a pleasure to attend your webinar. Thank you, Dr. Zog. Thank you, Dr. Anil. Thank you, Dr. Sanjay. And thank all the doctors who took time from their schedule and attended this. Thank you. Wish you a very pleasant evening and see you soon, sir.
Thank you, sir.
Thank you.
Thank you
You
so
can
much,
sign
sir.
off.
Thank you.
Thank
Bye.
you.